This is the section on definition of sacroiliac joint dysfunction. The sacroiliac, of course, is housed within the pelvis. Any movement in the SI also induces movement in the symphysis pubis, and the reverse of that is true. In fact, recent research has shown that movement in the hip joint causes micromotion in the symphysis pubis. The joint functions as a shock absorber, so it attenuates shock over time. Okay? So at heel strike, the pelvis undergoes movement and force goes up through the hemipelvis into sacrum, up into the upper body, and of course there's upper body weight coming down and influencing the structure as well. It's designed much more for stability than it is for mobility. Paradoxically, the small amount of movement in a normally functioning sacroiliac joint is actually critical for stability, and it's generally accepted. Even some of the most conservative writings in kinesiology and joint function agree that when the person is laying down, the sacrum will move in backward bending, and upon standing up, the sacrum will rotate anteriorly, which I like to call forward bending because everyone can readily visualize that. So when we can, we use clearer language. And so when the sacrum rotates forward within the ilia, it then draws the ilia together with ligaments, and you have a more stable structure. The sacroiliac joint also can act like a force transducer. It's changing forces coming on heel strike. Forces come up the lower extremity into the hip, into the ilium, through the SI, on up. And it changes the direction of that force. The pubic joint I like to define as more of a motor mount. It's so powerful. I think it gets underappreciated, and in the anatomy section we'll discuss how significant that connection is at the fibrocartilage and ligament interface. So it is primarily a shock absorber and force transducer. Its function is mobility, and further to that, if this pelvis was without joints, if it was a bony ring with the same design, it would readily fracture. Parts of it are remarkably thin. This part of the ilium, I can easily see light here and along here. Right here I can see light through this structure. And so there are parts of weakness within that bone. If you look at the trabeculae, they match the model of forces coming up through the ilium, up into the sacrum, on up, and the opposite thereof as well. It's also, the pelvis, of course, is a structure to house organs, to serve as muscular attachments for large, powerful muscles in trunk and in hip. So it does need to be stable for those functions. I much prefer the terminology lumbopelvic hip dysfunction over sacroiliac joint dysfunction. For obvious reasons, it's more of a systematic perspective. And again, there are times when we as clinicians don't know if we're really treating the joint with respect to changing position of ilium on sacrum, for example. Lots of research to support the fact that we don't know when we're doing that. I suspect that in time we'll have more data out there. I trust my hands when there's a palpable shift at the symphysis pubis. Then there has to be a concomitant shift at the sacroiliac joint, and when that, of course, is altered. That's what I mean, when there's a treatable discrepancy in the pubic joint, that is then corrected. I feel very strongly that that represents a movement dysfunction in the sacroiliac joint as well. However, much of what we name sacroiliac dysfunction is actually a dysfunction of the pelvis moving as a unit. So the pelvis can move in three-dimensional space during gait, and there are a large amount of deformable structures here that can cause it appear to represent rotation of the sacrum, for example, or torsion of the sacrum. The pelvis can move in tri-dimensional space in a person whose joints are bilaterally fused through a surgical process or through disease, and they will still move asymmetrically. So we cannot really trust asymmetrical landmarks. So we have to be cautious about stating that, well, your pelvic landmarks are asymmetrical, therefore you have sacroiliac dysfunction. It's a deeper inquiry before we can actually achieve that statement. Now, the function, of course, is that this structure have a normative amount of movement that's very, very small, study after study after study, using high standards such as that of stereophotogrammetry, which is the high standard of the industry for evaluating joint movement, repeatedly tells us that there's very small movement in that joint, but that motion is important. That is important for it to function in shock attenuation, force transmission. So that is a very important function thereof. So one of the dysfunctions in the joint would be an increase in motion, named hypermobility. A significant increase in motion would be named instability, and a significant decrease in motion is described as hypomobility, of which there are two types. One is a fixed hypomobility that will not change. An example is someone who has a pathological fusion in the joint. That joint is never going to move, and that hypomobility will not change. However, most of the population that we see in the clinic, we can improve their movement. There are reflexes that connect the pelvis and the hip with the upper cervical spine, and a loss of motion or a altered posture in that system based on that person's norm is going to create a reflex counter movement, counter posturing. And the purpose of that is that if someone walks with a twisted pelvis, they could easily bump into their neighbor walking down the sidewalk. But they walk straight down the sidewalk, and why is that so? Because way up high they counter rotate, and that allows the eyes to keep horizontal, actually keep symmetrical in all three planes, same for the inner ear, to function normatively. And then lastly, for the vasculature, for the oxygenation of the brain based on demand and based on size and vessel configuration, etc. So these reflexes are very powerful and very real. And so it does participate in that. And lastly, part of the strength of the pelvis is that it is induced, large forces are induced with simple day-to-day activities, just sitting in a chair repetitively, getting up and down, walking, running, twisting, those sorts of things. Those forces go through that, and it needs to be strong and dissipate those stresses. And again, without these joints, it would be pelvic fracture would be more common. There are some interesting mysteries about the pelvis, and I give the example of the first H1N1 virus case in the nation, who happened to be a physical therapist who happened to take my workshop. And he brought his MRI, and it was remarkable to see how moth-eaten that joint was. And so he got a secondary bacterial invasion of the sacroiliac joint. Was on antibiotics for quite some time, was in an induced coma for 30 days, etc. And in testing side glide movement of the pelvis, it was fascinating to observe that on the left side in which it was fused, pathologically, I could not induce left to right pelvic side glide. On the other side, it was very easy to take up the slack and then with an additional force induce mobility and feel the recoil. And since then I have found that whenever I have someone who presents with a fusion on one side, that side glide movement of the pelvis is absent on that side moving to the other side. You won't find that reported anywhere in the literature. I think it's just one of those interesting unknowns. But we will look at this structure through the lens of stability and of mobility, and we'll also address pain in another section. And of course, the function of it is to not be painful every time we induce large forces through it. It should function without those things. It should also report movement and stability through the receptors types 1, 2, and 3. And of course the type 4 is a nociceptor, so it needs to report this in real time so that the rest of the body functions in an integrated manner. So it's also part of the nervous system. The ligaments and the joint capsule certainly are part of the ligamentous system, which has mechanoreceptors that report body at rest, initiation of movement, end of movement, and ties in reflexes such as a very tight ligament would inhibit some muscle function, and then the opposite muscle would be, of course, would be stronger. So part of what we're doing with this structure in restoring normative movement is also restoring normative interaction between the mechanoreceptors and muscle function. And so that's another part of the function. Certainly needs stability and mobility, and a deviation from that norm is a classical description of dysfunction of the SI joint. So I think that serves as a good introduction, and we will stop here. Thank you.